do you think explains this?
We are seeing the numbers coming up really, and we note the enthusiasm is starting to pick up. But also we need also to open up more facilities, because as we started, we are also reviewing our own program management activities. Like we need to decentralize a little more. Initially we had thought, let's say, we'd have a few facilities for purposes of control and accountability and training. But we also realized that we need to involve all the health facilities, because we in this country have developed a very strong system for immunization services. I mean, the girls who are immunizing measles and rubella at a health center 3 can immunize the same vaccine with just a few updates and trainings. So we need also to decentralize a little more and bring the vaccine closer to the people. Because if you are going to ask somebody, let's say in Katakwi, that the facility of immunization is only at Katakwi district headquarters and has to drive or to walk, because there's not a lot of driving facilities in the rural areas. So we need to go a little more down at all our health facilities, our health center 3s, because they have fridges, they have the cold chain. This vaccine uses the same cold chain facilities like the normal measles vaccine, the normal polio vaccine. So now, and our health workers are trained, they have been immunizing all other conditions. So I think we are getting a bit closer to the people so that they can walk closer to the facilities. And in that way, with further intensified communication and encouraging the people to come, we anticipate in the next 2 weeks things should be fine. We should be raising up our numbers much faster.
All right. Thank you very much, DG. I'll be coming back to you. Professor Pontiano, right now, the world is talking about new variants, talking about mutation of the virus. But for a lay Ugandan out there, what does this exactly mean, and why should a Ugandan be worried? Because not many of such reports have been, cited in Uganda, although the PS has said we have now started seeing a surge in the numbers. Let's talk about these variants and what they mean, and what a Ugandan needs to know, the lay Ugandan.
I think when we talk about the variants, a simple way of explaining is the virus changing. It mutates, it changes itself, and creates some new strains that are different from the earlier ones. But I think we became very concerned when the UK variant, we call it the UK variant, was first identified, and was mentioned that it was easily transmissible. Yeah, and then later we also had in South Africa a new variant that came up, and again we had the stories that it was also more transmissible and was taking over from the earlier strains, and Brazil. So that was a worry, more transmissible. We don't know yet, there's no concrete evidence that these variants cause more severe disease, but this is also being studied. But we know that they are easily transmissible. Yeah. Then the other worry that people talk about, should we be worried if we do new variants? Shall we be able to detect them using the methods that we have? Again, we can assure our audience that yes, the methods we have can detect these variants. The other worry is, of course, the vaccine. Exactly. Or the vaccine work. So far, most of the vaccines that we have do work. The worry we had was in South Africa, where the AstraZeneca was mentioned was not working very well on mild and moderate disease. There was no concrete evidence for severe disease. That's why WHO is still encouraging us, even those where the variant is, to continue with this vaccine when we weigh the risks and the benefits. Okay. So for now, in Uganda, we should not be worried, but we are really following. This is one of the very active work we are doing in surveying, to see that we have, if in case we have seen some new variants in Uganda, but they are not worrying as yet. If we get to an extent where we are worried in terms of disease transmission, in terms of vaccine, we will inform the public.
All right. Well, that's great information coming out. Mr. Kware, at the height of COVID-19, the lockdown and everything, there are particular drugs that either were very highly priced and that need the specific need, the daily use of these drugs, including vitamin C and many others, came up. What has been your assessment of the situation, and do we still have these drugs in the amounts that we would need them as a country? Because they're being used even in the facilities where we're treating the COVID-19 patients.
Mildred, thank you very much for that question. I think what we observed at the height of the COVID pandemic is basically a simple issue of supply and demand.
Okay.
Once we ended up with a situation where there was high demand for vitamin C and other medicines that people believed would be beneficial in the treatment of COVID, there definitely was high demand. And normally in such a situation, it takes some time for the supply chain to adjust and for manufacturers and suppliers to produce sufficient quantities to be able to meet that demand. And that's why the prices went up. But right now, we rightly locked down and made sure we gave ourselves an opportunity to respond. The lockdown was very, very important for us on the supply chain side. It allowed us to prepare, to plan, to organize with our suppliers to make sure we can establish new agreements with them to make sure that we can get the commodities we need without the disease progressing through the population very, very rapidly.
Okay.
And by the time we opened up, we found that many of these items had actually normalized in price. So many of the commodities, like you have mentioned, you will find them now very much available on the market and even from NMS at very fair prices. And the prices have continued to come down even for the other items which were very difficult to source at the height of the pandemic. We had challenges getting PPEs, things like gloves were very hard to come by. But right now, as we speak, the prices are gradually coming down.
Okay.
And that is very, very important. I think the leadership from the Ministry of Health in choosing to make sure that we lock down, make sure we give ourselves enough time to prepare and to respond was very, very good. And that's why we find ourselves in this very healthy position where we have sufficient supplies at national medical stores to respond to the outbreak and to continue responding to the outbreak. And also we've seen a reduced number in the patients that we are getting.
All right, thank you very much. Let me come to you, Mr. Nahamia. Still within the COVID-19 pandemic, Ugandans have the habit of self-medication. We saw so many people walk into pharmacies or drug shops asking for either azithromycin, zinc, vitamin C, or hydroxychloroquine. What has been the assessment of the National Drug Authority, especially with regard to these medicines being given out without prescription from the medical workers? And the way forward, because many, now that Dr. Diana talked about the surge and the new variants, probably this is something that will continue.
Yeah, thank you very much, Mildred, for that question. First of all, you have to bear in mind that regulation of drugs is there to protect the health of the population and the safety of the population. Drug regulation is there to ensure that these commodities we regulate, they have good quality, safe and efficacious. Yeah, maybe I would like to say that these commodities are at the center of the healthcare system. If they are not there, you not achieve anything.
Yes.
So we regulate there from the manufacturer to the user. Maybe the question you have asked is at the end user now, whereby, of course, there was that surge when people were looking for these commodities, vitamin C, what people were saying that these are the commodities that are working. But we went out there and we encouraged people to follow the procedures, to stop self-medication, to first go and consult the clinicians, and to make sure they get the right treatment. And we also came out to make sure that the whole system is followed from the prescriber through the dispenser, the one who is dispensing. It's not a matter of just giving out those medicine like any other commodities, even to the patient, to adhere the prescribed drug. So we are out there trying to discourage the consumers, our population, to self-medicate.
Okay.
This is very dangerous.
All right.
And that's why we are there. We shall continue spreading the gospel against self-medication.
All right. Thank you very much. Mr. Nahamia, I'll definitely come back to you. Dr. Twine, there are lots of myths and a lot of misinformation that has gone on. You know, the talk of you don't take alcohol 45 days after vaccination, issues of blood clotting, the misinformation that has gone through. What do you make of these and the skepticism? Is it part erectile dysfunctions, some of the myths that have gone around? Could you just speak to Ugandans about some of this information that you've seen go out on social media, but also, do we have a policy for any person who gets adverse effects from the vaccine, like we've probably seen from other countries?
It is true that we have had a lot of misinformation, distortions, misconceptions. And it's not only just for COVID. Remember when we were doing rubella and measles campaign, we always get that part of the society that don't believe in whatever is being done, and because they have their different ways of reasoning. So is the issue of COVID vaccine, because as you said rightly, there has been so much misinformation out there. And I think at the beginning, it led to low uptake. I think that the people now have started getting confidence, but before it was a lot of, there was so much misinformation. And one of them is that alcohol, that when you take the vaccine, you have to keep away 55 days, which is not true. First of all, alcohol as a chemical in our bodies, the alcohol has an effect on the body, leave alone the vaccine. Mm-hmm. Even when you are going to take medication, if you are going for surgery, and you've been taking like a lot of alcohol, and I think this one refers to the heavy drinkers, because the liver in our bodies is the factory of the body. So anything that we take, whether medicine, whether food, whether everything, there is that breakdown, that finer breakdown of those products that we take in. And so the liver is our factory. So when you consume a lot of alcohol, it stimulates the liver to start making a lot of enzymes. And those enzymes, whatever you take in, it destroys for example, medicine. That's why you find for people who take a lot of alcohol, if you are going to give them anesthesia, you have to give them a little higher for them to sleep, because their liver is so active that it breaks down all those chemicals. So it is the same principle. We advise that when you take vaccine, do not take a lot of alcohol. Do not intoxicate your body. It is just for the good of the people. Mm. But there's no data, there's no evidence to show that when you have a vaccine, you have to keep away from alcohol for 40 days or 45 days. There's no science about that. But it refers really to those that do a lot of drinking, heavy drinkers, because every time you have that kind of alcohol in your body, it causes some kind of hyperactivity in the body, especially on the liver side. So that's what it is. But the other things, of course, clotting, like what we saw in Europe at one time when they suspended the use of the vaccine, citing that association of clotting. On further scrutiny of the data by World Health Organization, by also the regulators in Europe, they realized that the numbers of the people who are getting clots, they were not any higher than before the vaccination was undertaken. Okay. So it just happened that maybe it was coincidental that those people that had clots also, even if they had not gotten the vaccine, possibly they would have gotten the the clot. But also, it is very important to note that every vaccine, everything that we take in our bodies has side effects.
Okay.
And so we cannot say that it is completely, you know, there's nothing. You can get pain, you can get dizzy, you can get some of those side effects that we've been talking about. But when you look at the risks and the benefits of this vaccine, the benefits outweigh the risks. And that's why we are saying, with all those issues notwithstanding, the vaccine still, the benefit of taking the vaccine much.
But that is why I asked that in the case of any adverse effects, do we have a sort of protection policy? Because we all react differently to use of different medicines.
We do. We have also our guidelines on how to manage the side effects at all levels, right from the health center 3 up to the national level. And you'll ask yourself why we have been consenting people to consent, so that first of all they understand fully what the process we are going to undertake. Secondly, should they have any side effects, we would be able to manage those side effects. However, would not be held accountable. Like, you know, remember rubella measles campaign, when some of those children got reaction, and some people actually tried to take government to court, but they did not succeed because we were protected by the law. So yes, as a country, we have the mechanism, we have capacity, and we have also the guidelines that we follow to manage all those side effects.
Okay. Dr. Mwebesa, many have also talked about the efficacy of the vaccine, particularly AstraZeneca, the one that we are using in Uganda, based on a lot of information received from other countries, probably suspending it, others halting, the thousands of doses that they had procured. What can we speak about the efficacy of this particular vaccine that we have, AstraZeneca? Probably that could be one of the reasons that we are having a low uptake of the vaccination.
Thank you again, Mildred. Just to add to what PS had just talked about, we also have just completing on what she was talking about, we have even a dedicated committee which is monitoring for any side effects or adverse reactions. Okay. And we get forms which they fill, and we get feedback all the time. So far, we don't have any cases. The few cases that have been reported are minor side effects like headache, fever, cough, like that. So far, we don't have any known adverse effect out of the over 120,000 immunized people. Coming down to the efficacy of this, AstraZeneca in particular, of course, most of these vaccines are still on trial. Many of them are still being learned. We are still learning from them. It is said that it is around 62–64%. But we've also received recent information from WHO that once you get the second dose, at especially 8 weeks, then the efficacy rises substantially to over 80%, some extent to 90%. And it is actually even advised the longer you take it, the better. Like I've been seeing people trying to come back as soon as possible for the second dose. The minimum should be 2 months, which is 8 weeks. But it's even advised that if you take it up to after 12 weeks, it is even much better. The efficacy is much higher.
Okay. Yes. All right. And since we have taken long to come for the vaccination, I'm talking with regard to Ugandans, because some are asking when is the next batch coming, because there were particular groups, as the PS did mention, that were given for this first batch, but we are over 40 million Ugandans, or even to say half of that population will be taking up the vaccination. Are we thinking about the times we'll have a second batch of doses coming through, or we first have to deal with the first batch to be taken up?
Yes. What we agreed, and it was really a strategic decision, an operational decision, with the 964 doses that we have, 964,000 doses, that we first increase the coverage of the first dose. So we want to immunize everybody up to with the first dose.
Okay.
Then we are anticipating to receive the second consignment in May, which is a substantial amount, almost 2 million doses from the COVAX facility, which is funded by Gavi. But also government has paid for some doses from Serum Institute of India, which is also anticipated to come from about end of May and early June. So we anticipate that the first group which was vaccinated actually was on 10th May, you remember. I was one of those who received my jab. So we anticipate to receive our second jab on 10th May. But if you extend it to the 12 weeks, you can even get it towards the end of May. So that will be within time of the new consignment which is coming. So okay. Even if we used all these for the first jabs and cover as many people as possible, we'll be in time to get adequate vaccines to give the second jab.
That was the other worry, that we may use up all these vaccines and then the rest can take it. Professor Pontiano, of course, testing has now become a part of us. Probably you need to travel or you have a particular meeting that you are attending. But there are two types of testing that have been talked about, the PCR test and then the antigen test. Totally different pricings, but Ugandans are asking, what is the difference between these? Which one is more reliable that I can be able to use?
Okay. We know that the PCR, which looks, of course, for the virus in our body, is the most reliable and the most sensitive. It detects the virus, okay. And it is more sensitive in individuals who have been infected. But this PCR is a bit complicated. It requires specialized labs, specialized people who have trained. It's a little bit more not user-friendly when you go in what we call point of care, where people need. So there's been a desire to have some other tests that can be used quickly and cheaper. So the antigens have been recommended. But our studies and many other countries have shown that antigens are less sensitive than the PCR. They are less sensitive, and we have made a recommendation. We have evaluated a number of antigen tests that have come into the country. Most of them are fared very, very poorly. We have identified two where we have recommended that they can start rolling them out slowly in symptomatic individuals, in healthcare facilities, to allow quick intervention, quick intervention. We have not recommended them for people traveling to go out in the labs anyhow and get them, because they are not as sensitive. Many asymptomatic people who don't have symptoms, the test may not show anything, yet you have the virus. So that's the complication. We all would have loved to have these antigens, the point of care. But unfortunately, the technology is not allowing us as yet to have these kits good enough. So we are appealing, and we have been trying to educate. Don't use these antigen kits anyhow. They are still, we're recommending those who have symptoms in health facilities to allow quick intervention, and then later you can do other tests. If you are antigen negative but you are symptomatic, you can still, again, they can treat you, manage you as you do the PCR. So in summary, unfortunately, the more expensive PCR, which is not as user-friendly, is still the gold standard up to now.
And that is where the problem is, because many are asking Uganda Virus Research Institute what more research has been done to make the tests a little bit more affordable and more available to the Ugandans, to the people who need them.
And that's one of the things we have been doing. We were given a mandate by the Minister of Health to validate all the kits that are coming to the country. Of course, we have our colleagues who are working on diagnostic kits so that we get ours, but that takes a longer process. And what we need to do is to provide our population the best tests that are available. So for us, what we're doing, all the kits that come into the country, we evaluate them and we'll make recommendation to the Minister of Health so that people can have the best. And of course, we want to have the affordable. That's what I've told you. We have recommended some too that can be used, but again, in restricted settings.
Okay. Maybe before I get back to National Drug Authority and NMS, I want to come to you, PS, with regard to accountability. At the height of COVID-19, and we'll still remember this, because we had never seen a drive that would bring on board all Ugandans literally giving the little that they can be able to afford, both in kind and in cash. A lot was donated, monies, and also food, which was later on probably given out. But accountability still remains a key issue that Ugandans are asking, where did the money go?
Thank you, Mildred, and I think this is the right fora for us to talk about that. We received money from the private sector. We have a law in the country that guides how we manage all resources that we receive through donation. So Public Finance Management Act gives us the mechanism of taking back this money to consolidated account and then get this money reverted through supplementary release. And this was done. So that money, we got 29 billion in cash.
Okay.
And this money was taken to consolidated account. Remember that this was a requirement because you can't just use that money that you get like that. Then Parliament could not sit at that time because people were in campaigns. Mm-hmm. So after that, they reconvened and passed the supplementary budget. That money was got, and we are going to actually to start the work. We just received this money last week, and we are going to buy the vehicles that we're supposed to buy, because that was initial purpose why remember the call the president made. And so we are going to buy vehicles. We are going also to renovate, to put up some port health structures for our health workers. Remember that some border points, they lack the infrastructure. It has been very hard for our health workers at some of the border points, because they have nowhere to sleep. They are working in makeshift. So some of those places we are working on some port health at the borders, and then also to start on the work of 2 blood banks, Arua and Soroti. So that one we shall be able to tell the public once that process of procuring and once all that is done, Ugandans will definitely know, and so that money is intact. It is not utilized. It is not stolen, as the people were speculating. The donations that were received, for example, both at Office of the Prime Minister, in the local governments, at Ministry of Health, we have been able to account for each and everything that was
Because someone
received.
out there is thinking some were vehicles given out.
Some were vehicles. We deployed them wherever they needed them most, in the districts, in facilities. Some are actually the ones that are being used to carry the samples from all over the country to the center. So all those cars are working, and they are doing the work for which they were given. So
okay.
there's nothing that got lost, and there's no one who stole that money. So I just want to allay the anxiety of everyone listening. And it is very easy for people just to come up and claim, oh, money was stolen. But I think that is very wrong, and it demoralizes us who are at the front line, and generally to demonize people. It is sad.
All right.
We don't believe in stealing government resources. I personally don't believe that, and so there's no way that we are entrusted money from the private sector and then we use it for something else. That is an abomination to me.
Great that you have come out clear on that. Maybe much more time always to come out to the public and let them know about issues of accountability. Let me come to you, Mr. Nahamia. When you talk about the National Drug Authority, for a lay Ugandan out there, they are asking, what is this body about? What are they supposed to be doing for the country?
Yeah, thank you very much once again, Mildred. The National Drug Authority is the drug regulatory agency for this country, and we are there to ensure availability of efficacious, good quality health commodities, which include drugs and other consumables, like maybe gloves, for example. So our main mandate is to make sure these products are available. As I've already mentioned, the healthcare system cannot function very well unless these products are of good quality, safe and efficacious. And mind you, these commodities are very expensive. Maybe apart from the human resources, the biggest chunk of the budget goes to these health commodities. And if they have poor quality, may not achieve the objective of providing health care.
Okay.
And we even go to the extent at the use, appropriate use. The products may be of good quality, but if they're not appropriately used, you may not achieve the objective of treating the diseases. So that's why we're there.
Okay.
And we do it through several quality assurance measures. As I've already mentioned, we start from the kitchen. That is the manufacturer, whether foreign or local. It has to be inspected to make sure that the products, especially these drugs and other commodities, are manufactured according to what you call good manufacturing practices, which are internationally recognized. Then from there, we don't stop there. We do what we call market authorization. In the layman's language, is product registration. This is maybe what I may call documentary evidence through dossiers, which our technical team evaluates to make sure that the product or drug is of good quality, safe and efficacious. And we don't stop there. We also make sure that we do what we call import and export control. Even when these products are coming in at the port of entry, we have gazetted ports of entry, Busia, Malaba, and Entebbe. We make sure we inspect these products to make sure they comply with those standards which have been set. We even pick samples from there, from the consignment which is coming, and we take it for laboratory analysis.
Okay.
If we are not satisfied, we reject those products or drugs at the expense of the importer. That one is not enough. The product can come in when it's of good quality. But along the supply chain, it can deteriorate. They have already mentioned about the vaccine. It should be stored between 2 and 8 degrees centigrade. But do these entities along the supply chain, do they have those conditions? It can deteriorate along the supply chain, not only vaccines, but even other drugs. Therefore, from there we do what we call licensing of the drug outlets to make sure that these premises which are handling these products are suitable. We even give this in the law. We give suitability of premises. Are these premises suitable? There, we make sure that there's proper ventilation, temperatures are within the defined limits. And then, as I've already mentioned, even if the products are available and are not properly used, you will not achieve the objective. There is what we call rational use of drugs. So, before you give you that license, is there a qualified person to make sure that the drug or that health product is properly used?
Okay.
And then you don't even stop there. If you prescribe that drug and you dispense it properly, and the patient, the consumer, does not adhere to the instructions given by his physician or the pharmacist or dispenser, you will not achieve the objective. There will be treatment failure. So, we don't only stop there. Our PS and the DG were talking about the adverse events. These are events that come when the drug is already authorized. You expect, especially when you subject different populations and massively, adverse events can come out. And we have what we call pharmacovigilance. And we have a fully fledged unit on pharmacovigilance. Like in this COVID situation, We are there, our teams are there to make sure they record all those adverse events. And of course, people are only on COVID vaccine only, but we do for all.
Okay.
For all the drugs, and we can even take regulatory action. We can recall a drug if we find that the cost, after doing some cost-benefit analysis, we can do regulatory action by maybe recalling the product. Apart from that, we also do what we call post-market surveillance. The drug is already
in circulation.
In circulation, along the supply chain, as I already mentioned, from the manufacturer through the supply chain, the consumer. We go out and pick samples. Samples, through a scientific method, we subject them to laboratory testing. We have a lab, by the way, which is the WHO pre-qualified, one of the few in the region. It is at level 4. Even we have the lab is also ISO certified, 17025, by a lab from the United States of America. So we can also take regulatory action if we test and find it does not comply.
Okay.
We can recall the drug and destroy it. We don't only stop there. We also do what we call regulate clinical trials.
Okay. For drugs that are being developed.
Yes, we have so many, quite a number
Okay.
of trials that are going on. So, but all this, we don't do it alone. We also collaborate with other regulatory agencies, like the Allied Health Professional Council, Pharmaceutical Society, the consumers, the ministry. So we don't do it in isolation.
Okay. NDA is holistic from manufacturing to end user and even regulatory at that.
Yes.
Interesting. I will be getting back to you. Mr. Kware, when we talk about national medical stores, one is thinking about the medical aspect and the storage, also looking at the distribution from those stores to the end user, the person who is supposed to use this. Would like to know your mandate, but also speaking about the most critical aspect, drug stock outs in health facilities. How come we do have these?
Thank you very much, Mildred. Just as a segue, National Drug Authority and National Medical Stores were actually born on the same day.
Oh,
yeah, so I think at that point in time, government took a decision to make sure that we needed to have these two agencies within the health sector. So the mandate for National Medical Stores is quite straightforward. Our key mandate is to procure, store, and distribute essential medicines and health supplies, primarily to public health facilities. We say primarily public health facilities, those are the ones owned by government, but there are some commodities that we handle that we do also supply to the private sector. Some niche items like the vaccines that we have that you may be finding in private facilities, those are also procured and distributed from National Medical Stores. But over the years, our mandate has grown, and we have also started providing these commodities for the uniformed forces. So when you speak of the UPDF, NMS is also the provider for the essential medicines and health supplies there. The prisons and the police are now also our clients, and we're working very closely with them to make sure that we can provide supplies for them. In 2012, our mandate also expanded now to include vaccines, and that is how NMS has come to be the agency within the health sector that actually is receiving the COVID vaccine and distributing it across the country. We are also in advanced stages also of procuring additional AstraZeneca vaccine from Serum Institute. We do anticipate that by the end of May, we should be getting at least about another 1.2 million doses, and perhaps even next year, we'll be getting even about 5. Okay. But looking at our mandate, we have tried to crystallize our mandate and try and make sure that we can deliver it through two key objectives. We try, first of all, to make sure that we have the items that our health facilities require, which speaks to the question that you were asking about stockouts. How is it possible? Yet that is one of our key objectives. Now, for us to be able to have the items that our health facilities require, we go through a very rigorous process with more than 3,000 health facilities that we serve. We go through a process of demand estimation and forecasting. We try and anticipate and calculate with them what we think their needs for a whole financial year shall be. Now, it is based on these plans that we call procurement plans that NMS then holds inventory. We hold this inventory, and then we anticipate that these health facilities shall make orders in line with these plans that we have agreed with them. Now, the extent to which these plans are accurate determines whether the commodities that they shall be ordering shall be sufficient for them. Also, you should have at the back of your mind that NMS distributes commodities to these health facilities at least once every 2 months. Okay. Once every 2 months. So you need to appreciate here that when a health facility has planned and has ordered, we expect that these commodities shall subsist at least for a period of 2 months. So if you were to take a very simple example of malaria, and you say you're a health facility and you anticipate within the 2 months, you will have perhaps 100 cases and you need 100 doses. But if your planning was not good enough and somehow you ended up getting 200 clients within that 2-month period, that means the supplies that you planned for, the 100, shall only subsist for about 1 month. And then you may end up going 1 month without the supplies that you need. So the stockouts are normally born out of the accuracy of the plans that we are able to come up with the health facilities. Because the medicines are not manufactured and created the moment they are needed. We have to plan this well in advance. Many of the manufacturers we work with have very long lead times. Some of the raw materials have to come from abroad. So a lot of activities have to take place before medicines are actually provided for health facilities. So the quality of the planning normally is key. The reverse also happens. If, for example, a facility anticipates that they shall be requiring maybe 100 doses of a particular item, and somehow for, I don't know, for any good reason, they end up getting fewer cases, maybe half of that. Maybe there is an intervention, like we have bed nets which are being distributed across the country, and then you see less occurrences, for example, of a disease like malaria, then that will lead to the opposite, which is now somebody having an excess of what they have.
Take us through this process of ordering for the medicines from national medical stores and them being delivered. How rigorous is it, and how can we make it better? Because there have also been complaints, we've covered these in the media, where you'll find a health facility complain that we made the requisition, but it's taken a very long time for the medicines to arrive at the health facility.
We try and streamline the distribution of essential medicines to health facilities using what we call a delivery schedule. I think those in the health space will be very familiar with it. At one point, it was just a matter of everybody ordering at a go, and we were serving more than 3,000 health facilities. It was very difficult for us to have that well synchronized and in a planned way with our suppliers as well. So we developed what we call a delivery schedule. It is basically our charter with our clients. It is our social contract with them. It is a document which basically stipulates that if a health facility can have their order placed with us on a certain date, NMS undertakes to make sure that they deliver the commodities by a certain date. Okay. So everybody has to work within that framework. That is how we try and bring order within the supply chain. But when you have issues of somebody not planning well enough and the commodities are not enough to subsist until the next delivery, that is when you start seeing scenarios where somebody may run out of supplies. But then again, the opposite may happen, where somebody actually planned for some commodities, but actually it took him longer than they need. So it is a very difficult science to actually get accurately done. Right now, we're working very closely with the health facilities to see how we can improve on the forecasting, because if we have much better plans with them, we believe we can get much closer to 100% availability. All right. Right now, we believe our forecasting accuracy is about 80%, and that has improved a lot from the past days. And we believe very soon we shall be able to crack even the 90% and even get closer to 100. And once we are able to articulate our needs well enough, we believe that we can provide better service for the health facilities. All right, thank you. Maybe just shortly before we take a break, because we are due for that, Dr. Twine, we've definitely, and this is a normal, occurrence, that people will complain about drug stockouts. I want us to look at the balance, like Mr. Okare said, the balance between health facilities that will have more than they need, or what they need, what they anticipated, but did not receive the cases to use them up, and those that requested for what they need and use them up, or even do not get as much as they need. Is there a correlation of what I would call sharing, for lack of a better word? Because we've sometimes seen at the end of a financial year, government spending millions and billions of money to burn out medicines that have expired, and yet in some other health centers, the medicines are needed, but they weren't available at a particular time.
Even in the best facilities globally, you'll get medicines that will expire. That one, you'll never get anywhere, any facility that will have zero expiries. But what we do is that when these medicines are delivered to the district facilities or the health facilities, there is a mechanism, a local mechanism, where each facility, if you have excesses, then through either the district authority, through district health officer, or inter-facility connection, then they exchange or they redistribute. So we do redistribute to ensure that we do not have a
Is
lot
that
of...
at will? Like Health Center A can discuss with Health Center
Yes,
B?
because you see, if all the facilities, for example, under one district, they are under one umbrella of the supervisor, that is the district health officer. So if facility A has a lot of medicine and facility B has run out of medicine, there can be exchange where you pick these medicines and redistribute, provided these medicines are properly documented and they are accounted for, because we have seen also some people where they would go and pick medicines in the name of redistribution, and then they don't take where they are supposed to. But as long as there is that transparency and the mechanism is very clear, then redistribution would reduce significantly a lot of stockouts in some facilities, and also stop the excesses and unnecessary expiries. But also better projection. What Paul is talking about is actually to get to that level of accuracy where people will be able to predict and know that in a month we use so much. In a month of this medicine, we need this much, so that they don't either over order or they don't also underestimate. That is where we are going.
Okay.
And I think when we digitalize our facilities, and I'm glad even, for example, at national medical stores, they have gotten now a system where it is very quick to order. But now at the facility level, that's where I want really to strengthen the digitalization, so that all the medicines are captured in the system, and just a click of a button, you are able to estimate how much of a particular drug, how much you have prescribed. And that way, then it forms clearly what you actually need. Okay. But also, we want to say that even partly, the stockout is not really because just the districts do not order accurately sometimes. It is because still the medicines that we have, the budget and the demand in the facilities is much, much more than what the budget can support.
Okay.
So it is all about really increasing the budget for the medicines, and we want to thank Minister of Finance. I think this year they have added some more money for the medicines. And if you look at how many, for example, for the last 10 years, the budget for medicines has significantly increased. But still we cannot say that we have reached where we want to be, and therefore we cannot say that we have adequate financing for medicines.
All right, Doctor, we'll be getting back to you now. There are aspects of infrastructure and the service, the quality of service that is delivered at the different health centers, regulation when it comes to the private sector and the kind of service that they do provide. But also on the other side, you've heard about so many adverts talking about herbal medicine. Let's discuss conventional and herbal medicine in one particular aspect, and much more of that when we do return from the break.
Every single day, a thought crosses one's mind on how it can be better. We want more. Matter of fact, for many of us, we deserve more. But do we know who to ask for what in as far as Uganda's health system goes? From accessibility to healthcare across Uganda to service quality, how much has been done and how much more is in the pipeline. Spotlight this Easter Monday addresses Uganda's healthcare status while shining a light on where we are and the future. On the panel, Dr. Diana Atwini, the Permanent Secretary of the Ministry of Health, Dr. Henry Mwebesa, the Director General Health Services at the Ministry of Health, David Nahamya, the Secretary to the Authority of the National Drug Authority, Moses Kamabale, the General Manager of National Medical Stores, and Professor Pontiano Karebu, the Director of the Uganda Virus Research Institute, as moderated by Mildred Tuhaise. Spotlight UG, Mondays at 10 p.m, live on UBC Television.
Wait.
No one should stop you from finishing what's yours. That's why MTN gives you data bundles that don't expire. Load MTN Freedom Bundles using My MTN app and enjoy the freedom to finish your data bundles.
MTN.
It's no secret that ICT makes learning easy.
The strides made in our field could not be possible without it.
And now we can watch our favorite show.
My radio is my best friend.
UCC provides an enabling regulatory environment and policy guidance for healthy competition. We also facilitate ease of doing business in the communications sector through licensing, standardization, spectrum management, tariff regulation, rural communication development, and consumer empowerment. An informed consumer is an empowered consumer. UCC supports local content and innovations. Driving the development of a robust communication sector in Uganda is Uganda Communications Commission.
That's their way of stopping HIV. What about you?
Today tastes like a new tradition, like an old favorite. Tastes like all hands on deck and all eyes on the prize. Today tastes like a piece of the action. And it never tasted this good.
Leaders who care create a good learning environment.
Because a good school equals a better life.
Raising voices.
Today tastes like a new tradition, like an old favorite. Tastes like all hands on deck and all eyes on the prize. Today tastes like a piece of the action. And it never tasted this good.
Winston Churchill named it the Pearl of Africa. Uganda is probably one of the most gifted countries in the world. The people, the food, the love, the climate, the culture, the scenery, and the peace and tranquility. Join us as we take you through the journey, live and exclusive to UBC, your public broadcaster, inspiring Uganda.
It is intellectually engaging.
Court does not sit to waste its time. If you have no defense, it chases you.
It is a ruling on the foundations. Business has been conducted in a certain way.
Banks take money from us, depositors.
Your health matters, and every single day a thought crosses one's mind on how it can be better. We want
Uganda, looking at the far that we've come and where exactly we want to go. Of course, there are challenges along the way, but how can we be able to deal with the challenges that the health sector does face to ensure that we get a better healthcare system? Hashtag is SPOTLIGHTUG, and this is live on NBS TV and UBC television, inspiring Uganda. We'll continue with the discussion particularly, and I'd like to start off with you, Professor Pontiano. Looking at the Uganda Virus Research Institute, I think now it has been pronounced more because we are talking about the COVID-19 virus or the coronavirus itself, but probably not many Ugandans know more about the Uganda Virus Institute. If you could just give us a bit of highlights about the work you do and your mandate.
Okay, thank you very much. Indeed, there are many who didn't know us, but it's an old institution that was started in 1936 by the Rockefeller Foundation to study a virus, a disease called yellow fever. In the 50s, it became part of the East African community and was the East African Virus Research Institute until the collapse of the East African community in the 70s, when it became the Uganda Virus Research Institute. Our mandate is to engage in health research pertaining to human infections and diseases associated or linked to viral etiology, provide expert advice, communication, partnerships, and they serve as a center of training and education. I think we're under the Ministry of Health, and our work, we do research, we do surveillance, we do diagnostics. When you do research, the public will not know you a lot. The public in health mostly know those who are providing services in hospitals, health facilities. Those are the ones they will know. But behind the scene, there are institutions like ours that do research. For instance, if I give you an example of HIV, a lot of the treatment, the prevention, knowing the risk factors for HIV, all came out of research, and part of that was done by the Uganda Virus Research Institute. Normally, I remind people, when the HIV had just come, people were worried. How is HIV transmitted? Will mosquitoes transmit? If they bite me? All that information research that helped us to understand what are the risks, who transmits, what are the risk factors, come from research, then they feed into policy and practice, so we do a lot of research. Some people in the health, in the medical field have known virus as an institution where viruses like Zika were first discovered, West Nile, and the rest. Others know us when there are outbreaks. When you hear, and I tell my colleagues in the Ministry of Health, when there's an outbreak and they say, oh, we have diagnosed Ebola or Marburg, we say the Ministry of Health. And I tell my colleagues, put in the brackets at the Uganda Virus Research Institute so that they can know us. People will say,
they shouldn't sign alone.
Exactly. The Minister of Health has identified that there's Ebola in Western. Yeah, but that's good, Minister of Health, but the Uganda Virus Research Institute, so that people can know us. It's a very, if you come to our institute, it's state-of-the-art laboratories that we have. It's a center of excellence in terms of research, discoveries, in terms of training and all that. But we don't work alone. We work with government, but with many partners, and wouldn't be where we are without these partners.
Okay.
So indeed, our institution does a lot of research, surveillance, diagnostic. For instance, some of the more recent viruses we discovered, Ebola bundibujo, which people didn't know.
No.
Marburg, the bats, the role of the bats in the transmission of Marburg. A person walking outside, that's not so important to that person. But in the medical field, in research, it is so important that we make these discoveries. Now, in the rollout of antiretrovirus, we're surveying, looking for HIV drug resistance, which is a new threat as we roll out antiretrovirus. And we have the labs that test, that inform the ministry. Recently, we have changed our treatment guidelines to use other drugs in first line because of the work we do. So we do a lot of work. You can advise us how we can be more visible and become, so that we're more known.
All right. I know that you host, as a Uganda Virus Research Institute, more than 7 national and international laboratories. If you could just highlight a few for our viewers, and how does Uganda gain from you hosting such laboratories that are international and on a national level?
Yeah, they're international. Our labs are international. They have international accreditations. Some serve not only the country but the region. For instance, the expanded program on immunization, a laboratory serves Congo, South Sudan, Burundi, and all that, in measles and polio. We have a lab, that yellow fever lab. The second, there are two in Africa that are international reference lab for yellow fever. One in South Africa and another one in Uganda. The labs for influenza, National Reference Lab for influenza, is based at the Uganda Virus Research Institute. Now we are a reference lab for COVID, both a WHO and Africa CDC reference lab. Some of these were WHO reference lab for the region. HIV, we're the national reference lab for HIV diagnostic since the start of the pandemic in 1980s. So we have a number of these international labs that are at the international standards.
Okay.
Yeah.
Interesting. Much more media engagement that needs to be, so Ugandans can get to know about you. Dr. Mwebesa, the Ministry of Health, whereas it has come under scrutiny with regards to a number of issues, and some of these are occasional, they happen occasionally, there are a bit of successes that have come through, including infrastructural successes, the hospitals that have been built, the health centers. Can we just pay attention to those and their capacity to handle the 40 million population? Because whereas you are building more hospitals, we are giving birth to more and more babies in Uganda, and they will definitely need the medical attention.
Thank you very much, Mildred. You started with a good sentence earlier when we were starting this show, when you said that when somebody gets a problem in a health facility, that can never be corrected. Because if you came with your wife, and maybe because of a mistake in our health facility, that mother is lost, that will never be corrected. And unfortunately, that's what sometimes defines us. People look at one mistake and forget the too many other good things that have happened. But of course, it's understandable. If I'm okay and I come, I bring my mother to be delivered, my wife to be delivered in a neighbor hospital, for example. And through some level of not attention to that mother is lost. Mr. Okel will not realize that these same midwives delivered 1,100 mothers the previous month very successfully. And unfortunately, that's what goes to be portrayed as what Ministry of Health is, the cases we have lost. But what I really want to emphasize is that despite a few mistakes here and there are so many tremendous positive things that are being done in our health facilities. A lot of deliveries are being done in our health facilities by midwives, by staff, and these clients leave the hospital very happy and happy with the system. But of course, occasionally, we have those challenges, but as management, we try our best to train our health workers, to supervise them, to make sure that even those negative cases, we do not support them or we do not encourage them. They must do everything possible to address those challenges. So coming back to your question, in line with the Ministry of Health strategies, because we are now going to infrastructure and the like, but let me first also emphasize that in the Ministry of Health, most of our challenges, the burden of disease in this country is diseases which are preventable. Over 75% of the diseases in our country here are preventable. So the strategy of the Ministry of Health is to emphasize preventive services.
Okay.
Even before we go to hospitals, even before we go to big equipment, before we go to construction of many hospitals, which we can discuss also, before we construct the big hospitals. But the emphasis of the Ministry of Health is health promotion and disease prevention.
Okay.
And as a result of that, we have intervened in a number of programs which have lowered the burden of disease in this country. Through challenges, through interventions like immunization, we have immunized. When, for instance, the NRM came to power by around 1986-87, the immunization rate in this country was 34%. Now, over 90% of our children are immunized. And that allows us to prevent childhood deaths. At that time, we were losing about 120 out of 1,000 live births. All those children now are being saved. We are losing only about 43 out of 1,000. We have strengthened our program for malaria control, that although malaria still remains one of the biggest killers in this country, but we have brought down the burden so much to the extent that, let's say, 7 years ago, the prevalence of malaria in this country was 42%, around 2011. Around 2016, it had dropped to 19. Today, the prevalence is around 9%. What does that mean? If you looked at a population of around 100 people, you'll find 9 people having malaria in that area, going away from 42% about 8 years ago. The same with HIV. We have brought down the burden of the disease. I know I've digressed from your question, but I really am trying to show you what the government has done in the past 15 or 20 years to bring the burden of disease in this country through especially interventions that help us to prevent disease and promote health. HIV, we have controlled HIV from a prevalence of over 18 about 20 years ago to currently 6%. And out of 1.4 million positive cases, estimated positive cases, we have put about 1.3 million on treatment. And that means they have lived better quality life. And that means they are also preventing spread of the disease. Because when we treat them promptly with antiretroviral viruses, antiretroviral treatment, then they are not able to spread the disease. And the same with TB and leprosy, we have brought down the diseases. Non-communicable diseases, we have brought back down the incidence of most of those diseases. Okay. So I wanted really to emphasize what government has done to reduce the burden of disease in this country.
Work in progress.
And work in progress.
Yeah. All right, and this is when, what brings me to Dr. Twine. You clearly talked about what I said earlier, the mistakes that could be done. Some of these are mistakes out of recklessness, and we've had a number of these cases come through, reported in the media. Some of these issues are in private health facilities, but others are also in the government health facilities. And someone is definitely asking, how do you, number one, deal with issues of recklessness? How does a patient get to report in case I have an issue with either a private medical health facility or a government health facility? How do I come through as a Ministry of Health with aspects of regulation?
Before you go to regulation, Ministry of Health has come up with the client charter.
Okay.
Now that client charter has the details of the responsibility of the patient and also the responsibility the caregiver.
Okay.
What the patient should do in case they are not satisfied. Now, in summary, we have also our regulators, the regulators of practice. We have the councils. We have nursing councils. We have the medical and practitioners council. We have pharmacy regulators. We have the allied health, the one that regulates the clinical officers, the laboratory people. All those regulatory organs are supposed to receive complaints. When something like that happens, there is a mechanism of writing and expressing your dissatisfaction to those regulators. And I think maybe in future we'll ask them here to come and explain to the public what the public should do in case of something like that. But we have the regulators that are supposed to follow up those complaints and make sure that they investigate the case as it is, and then they hold people who are responsible accountable.
Okay.
But if it is also, sometimes negligence can be categorized as criminal or non-criminal negligence. The criminal, the police can investigate, but really, by and large, we have in-country mechanism to ensure that when we have something like that, the population can seek redress, and for sure they will follow up those issues. Right. You just need to strengthen our regulatory framework, but they are there.
Okay, thank you very much. Just quite a lot to cover in health. Let me come to you, Mr. Nahamia, on National Drug Authority. We've definitely had lots of adverts in whichever manner to try and bring people closer to the attention of herbal medicine. What is your connection with regulation of herbal medicine? How many herbal products do we even have in Uganda? And what is your correlation with UNBS with regard to standardizing these herbal medicines?
Yeah, thank you very much, Mildred, for that question. Maybe I wanted to remind you that our mandate, by the way, is not only for human. We also regulate both human and veterinary medicines. So I wanted to put that clear, so that because we started with COVID, but most of these drugs cut across, but there are those which are specific for vet. Even for vet, by the way, they are herbal medicine for vet. Okay. There are also those which are for human. So for us, under our definition, whether it is herbal or conventional, it is a drug. Therefore, we have the mandate. But I know what has been there was this illegal advertising. By the way, it is illegal for you to advertise any drug without having it vetted by National Drug Authority. Of course.
So are you trying to say that a lot of these drugs that have been advertised without being vetted?
Of course, they were there, but we are closing on them. The other day, we had a meeting with UCC, with Uganda National Bureau of Standards. We just agreed on the way how to move forward, and we have agreed that, of course, they were hiding under health drinks, for example. They would say this is a health drink, but you'd get somebody advertising it as a drug, claiming some legal therapeutic claims. The moment you go that side, then it becomes a drug. Therefore, we have agreed with UCC, and it is helping us. If you have observed, there is a reduction. There is a reduction in those illegal adverts. And of course, I would like to inform you that the law on complementary medicine has also been passed. It is in the process of being operationalized. There we shall define who is a herbalist.
Okay.
For example, what are the qualifications of a herbalist? And for us, in that law, we shall be looking at the product, the drug. I would like to inform you that as I talk now, we have more than 100 products, local products, herbal, which have been, which are on our register. So out there are also good people there who are doing a good job. Remember that traditionally, some of these products are known to have some therapeutic activities, and those who are serious have been working with us, and we are giving them technical advice to really to make sure they put everything in line with our guidelines so that they comply with the standards. Also out there are those who have been a bit elusive and mixing the conventional conventional drugs with the herbal and trying to deceive the public that they are giving herbal drugs whereas they have mixed with. But we have the capacity, we have the state of equipment to analyze some of those products. We have analyzed them. Those who have found adulterated with conventional drugs, for example, the one which is very common is Viagra. We have taken action. We have recalled the products. They have been destroyed at the expense of those culprits. Some of them have been even taken to the courts of law. So all is not lost. There are good people there who are doing the right job. We shall work with those, make sure we even help them on these issues I've been talking about, good manufacturing practices. How do you formulate this herbal product, maybe from the leaf? How can you transform that to a tablet, for example? How can you formulate that into a liquid or a syrup? We are giving all that technical advice.
Okay.
And those who really, as I talk now, we have more than 100 products on the register. Some of them are doing very well. But we are not sleeping. We are watching.
What safeguard measures do you give to the final consumer, the Ugandan, who is looking for a therapy for a particular ailment, and they do not know which is the right herbal, which is not the right one to deal with?
That's why we have a register. We have a register. They are there, on the register, and we also advise our consumers to buy from NDA licensed drug outlets. But by the way, for your information, we are not regulating that person, that grandmother of yours there, who is cutting a few leaves and giving somebody in that community. We are not yet there. Okay. That one is allowed traditionally, it is known. And that's why you start from such information, you work backwards, and you do a lot of research is being done in some of those products. Even some people have even gone ahead to look for those plants which have activity against cancer. There are those who are researching against even COVID. There are those who are trying to go in that line. But we are there to give technical advice.
Okay.
Yeah. So all is not lost. There is that complementary law, I think, which we are still operationalizing.
Okay, there is still hope, at least like you have said. Mr. Okore, we are in the digital age, and we're talking about the fourth industrial revolution, and the question many people are asking, how far with the digitalization process of the national medical stores? I know that you've come up with a number of apps, the Smart Care app, you've come up with the economic resource planning tool. If you could just speak about those and the digitalization, which would actually even help better health facilities in terms of asking for these drugs from you.
Okay. Thank you very much. To paint a picture of exactly how far we've gone, I think it's important for us to appreciate where we've come from. On our primary mandate of making sure that we have commodities available in public health facilities to be able to treat patients, about 10 years ago, 2009 about, reports from the Ministry of Health indicated that the availability of these medicines in the public health facilities was at about 21%. So over the past 10 years, NMS has been innovating in so many different ways to see how this availability can be improved. By 2020, the same reports from the Ministry of Health indicate that availability now within the health facilities is at 81%, which is a tremendous improvement and much higher than many of our countries within the region. Now, for us to take it even much higher, to crack the 90% and even get closer to 100%, we believe we need to innovate one more time. And this is now why we are looking at IT systems. NMS is working with several systems within that corporation to manage inventory, to manage the finances, to manage HR. You've just mentioned about some very important apps that we have, like Smart Care, for which even we won awards for. We've got so many tools that we use. But the challenge with us now in trying to make sure that we have a supply chain that can effectively work together is that we need all these systems to speak together. That is why in 2018, we launched what we call NMS Plus. This is an enterprise resource planner software, and it is a system that we believe is going to give us visibility across the entire supply chain. We want to see how we can connect our suppliers with our warehouse all the way up to the health facility so that we can start sharing information. Very importantly, the demand side from the health facilities. We want to have a system now where we can actually start receiving the orders from facilities electronically. One of the difficulties we've had in working with the health facilities is that a lot of the processes have been paper-based. People send emails and use whatever different tools that they have. The ministry has so many, some for HIV, some for TB, some for lab. And we want to see how we can streamline all that information flow into a single platform that we are calling NMS Plus. So this was launched in 2018. And so far, we have 2 modules that have gone live. We have the HR module, which is working very well. And we have the finance module as well. And we're expecting that by the first day of next financial year, we should be able to go live with the rest of the modules. It is quite a significant investment in this IT system. We've gotten support from partners, and the total cost of this is going to be about $10.3 million just for the software and for the hardware as well as some training for the health facilities. Yeah, some of these systems do cost quite a bit of money, but we believe if we can have better information flowing through the supply chain, we can then see ourselves move to the next level where we can start making much better decisions because we have much better information coming from the health facilities.
While you're speaking about this, I'm looking at your capacity, your storage capacity. You talked about the warehouses. Do you have enough? The population is growing. That means the needs will grow, and the different medicines needed for the different health conditions. The obs and gyn medicines are not the pediatric medicines you'll need, or medicines for HIV and TB and all this. Do you have the capacity? Do you have the storage capacity for these drugs for the whole country?
That is another area where we are also investing very heavily to make sure that we can keep up with the demand. If I could just share with you some information, about 5 years ago, our budget for the public sector, the money we're getting from the government for the provision of the essential medicines was about 200 billion. As we prepare to go into next financial year, we see ourselves receiving from government in excess of 500 billion, which is more than a doubling. Just last financial year, we were able to go beyond 1 trillion worth of essential medicines in throughput. We actually distributed medicines worth 1,081 billion, which is quite significant for us. And we have been able to do this with the infrastructure that is more than 10 years old. We've been able to do it with the same number of staff and the IT systems. So in the area of the adequacy of the storage space, we still believe we also need to make sure that we make improvements in that area. It's for that reason that we are actually in the final stages of the construction of a brand new state-of-the-art pharmaceutical warehouse in Kajansi. It's going to have 30,000 pallet locations, which is more than 4 times the current capacity that we have in Entebbe. And this is going to be additional space. This is what we're going to be adding to the capacity that we have right now. It will allow us hold bigger buffers of medicine so that we can be able to ride supply chain volatility, especially on the side of the suppliers. Also help us be more responsive to volatility in demand from the health facilities, and overall also help us have better throughput and the speed with which we can actually convey essential medicines down to the individual health facilities. So that is something we're very excited about. It's not that often you work in an agency where you can positively impact the lives of more than 40 million people. So we're excited about it. We're excited about our work. We're all passionate about it, and we get up and go to work very excited every day.
And we will, as a media, definitely follow up on some of those issues that you were talking about. Let me go to Professor Pontiano. The Uganda Virus Research Institute and its contribution to treatment and care. What has been your contribution in that sector?
Maybe I'll specifically talk about HIV in terms of treatment and care. Uganda Virus Institute, working with its partners from the beginning, before even antiretrovirals were discovered. We did a lot of work in management of infections in individuals who are HIV infected, in prevention of some of the diseases like meningitis, the use of a drug called fluconazole that is used to prevent development of meningitis. Some of those studies were done by our groups. The use of septrin, its importance, our group did quite a lot. In terms of treatment antiretrovirals, when these came out, we did one of the largest studies in Africa to see how antiretroviral, it was called a DAT study. We worked with the Joint Clinical Research Center and other centers in Zimbabwe to see how we can roll out antiretrovirals in a safe way to treat and to manage HIV. In terms of prevention, we have done a lot in microbicide. Now we have even a new approach using a ring called the PIV ring. And our scientists were part of the studies that found that this ring could prevent HIV transmission. More recently, we have been part of the study that has shown that a long injectable drug called cabotegravir can prevent the transmission of HIV. Vaccines, we have done a lot of work in vaccines. So we have done quite a lot in delivery, how we can deliver antiretrovirals in terms of care for HIV. But the challenge, many of the viruses, we don't have treatment. So viruses are very, very difficult, and we don't have treatment. A lot of our work has been in vaccines. We do a lot of vaccine work, research in other viruses, Ebola, Rift Valley. Now we have a very large study trying an Ebola vaccine, working with our colleagues in Mbarara, epicenter there. In fact, using one of the vectors that is now being talked about in COVID, the Aden 26. We have been using it as a vaccine for Ebola.
Okay.
Yeah. So those are some of the areas in terms of care and treatment.
So you do the research, which will definitely lead to the implementation of what drugs come through and what services are provided.
Yes.
Dr. Twine, on the issue of healthcare, definitely will be staffing levels, which continue to be a point of concern in the different healthcare facilities, including the referrals that we do have across the country. How are you dealing with these? Because for example, we've covered a number of stories where the staffing levels in some areas is way below the average, below the expected healthcare facilitators who are supposed to be there.
Thank you so much. It is true, a number of years back, some districts, their staffing levels were as low as 45. But I want to say that government has prioritized increase of the human resource in our facilities. And as I talk now, I think on average the districts are at, even our facilities, they're at about over 70%, like 75%. And we hope that after we do restructuring and we come up with a new structure, we will see more health workers, because right now our facilities are still operating at the old structures that we had, and yet the numbers of the Ugandans have increased, and therefore we want to restructure and come up with more numbers that we meet now that the new demand, because of the new technologies, new ways of treatment. We cannot be operating at the old structures, because there are some areas that we need new skills. So that's why now we are discussing the restructuring, and we have seen more numbers of our health workers. Actually, we would have had even more if we had not had more districts, more sub-counties, more administrative units that are being created, but also we have been also upgrading more facilities. So you find that because of the limitation in the wage bill, we just divide, we use the existing the staff to even to take care of those new upgraded facilities.
Okay.
But I want to say that right now, for example, next financial year, we are going to see almost all our health center tools that were upgraded to Health Center 3. We have worked on about over 300 facilities, and we are going to see all those health facilities have upgraded and have more staff recruited, and therefore the numbers in each district is going to increase significantly.
Two key issues that will come out of the different health facilities. One is, I don't know if moonlighting, for lack of a best word to use, would be that there is the sharing of time between doctors or health medics between the private healthcare centers and the government, that when you need a doctor at a government facility, they will let you know that he is at a private care facility. That is one. But secondly, also, many Ugandans have decried the habit of having to pay money even when they are in government health facilities. How better can we deal with such a situation? Is this something that has come to your attention?
By policy, we do not condone dual employment. For example, where a health worker works in Mulago and then has to go to a private facility. But we could not hold the people accountable because the money that government was paying them was not sufficient to take care of their needs. Therefore, we kind of, looked the other way. But as we are moving now towards to better pay and increase in the wage, we are going to have a policy shift, and I think this has been already discussed. And as soon as our health workers are able to be paid a better wage, we are going to see that implemented, and therefore people will have to choose.
Do you have a particular time frame for this, doctor? Sorry to interrupt.
We can't determine this alone because we are not, I think there are other ministries that are responsible, Ministry of Finance, Ministry of Public Service, and so all of us are in this, but we cannot give you the time frame because that will be subject of availability of resources and when we are actually able to provide adequate resources. Now, after you talked about the charging. Charging in our facilities is illegal, and therefore anyone who takes money from patients is doing it illegally. But I want also to tell you that our health workers are not corrupt alone. Even the people who give money, they are corrupt, and they don't report them, they don't expose them, they condone, therefore the habit continues. Because it's not easy for us in the Ministry of Health to go and policing every person in their consultation room to know whether they're getting money or not. However, we have clearly communicated to our hospitals, right from lower units up to the national level. In the big hospitals, we have what we call private wing. If you have your money and you don't want to share with other people, the patient should be given that opportunity to choose. And therefore you can go to the private wing and you pay and you have your facility and you're taken care of. But it should not be that everyone who comes to a facility should be asked for that money. And therefore we ask the population that anyone asking for money illegally and you are getting money under the table, the only way we are going to work together and to stamp out this is when people come out and expose those people who are doing it. Then also, as you know, our laws are very tricky. You can't do anything until you are guilty. How do you get guilty?
Sometimes the people have said they are at the edge. You are at a facility, there's so many people who need this attention, you have a patient. Humanly, you would like to look at paying attention to your patient first.
You pay, but expose. Talk about it.
But you got the service.
I got the service, but so-and-so extorted money from me. Thank you very much. You gave me a service, but this is wrong, and I'm going to talk to your supervisor that this is very wrong what you did. It's illegal, and therefore your supervisor must know about it. So if you're in a hospital, in a facility, they look for the DH or they look for the accounting officer of that district, who is the head of public servants in that district, and that is COW. Even sub-county chief at sub-county level is representing COW. Talk about it. Expose and say, this particular person asked money from me. I know that this is a facility that is a government, or the services are paid for by government, but I was made to pay. And therefore, by doing that, you are helping government to actually fight the disease, or the disease of corruption. But if you just keep quiet and just go out and then talk about, then you are not helping. You are actually condoning, and legally, even you who gave the money, you are part of that. If one is to take you on legally, even the person who parts with money is responsible.
Okay.
Yes.
Thank you very much, Doctor. Sometimes it's a choice between life and, having to let this money out for many of the people that have been talked to.
Then expose
later on.
Don't talk about, don't just talk in corridors. Talk to the relevant people who are actually supervising those officers.
All right. A key issue, Dr. Mwebesa, that contributes partly to this is the welfare, which the Dr. Twine has talked about. How much is the Ministry of Health thinking about the welfare of the health workers? I grew up in a hospital quarters, so I clearly knew that my mom is next to the hospital. Anytime she was needed, it was just a call away, and in a few minutes, she would get there. We've covered stories of medics who have to travel kilometers just to get to their workplace, and sometimes get there very late, and health conditions are emergencies sometimes.
Good, thank you very much, Mildred. Actually, that's a very important point. On top of salaries and all the other facilitation, we need to look at accommodation for health workers. And the government has prioritized that. We have done a lot of staff houses for most of our health facilities. If you start at the health centers, we have put a number of health facilities. Over 500 staff houses have been built at the lower level health facilities. At the regional referral hospitals, we prioritized the accommodation for regional referral hospitals. Most of the regional referral hospitals have put up very good housing units, estates, and apartments, which are able especially to accommodate the critical staff, the midwives who deliver mothers at night, the anesthetists who are called for operations late in the night, the surgeon, the doctors. So we prioritize housing accommodation, even as far as Karamoja, we are prioritized there with support from Italian Corporation. We are building over 68 houses, staff houses, and we are even going to build more. We are building more staff houses under the World Bank support, especially as we are building health center series. Now we are having a health center. We are building a health center series for every sub-county. Actually, if it was not for the new subdivisions of sub-counties, by the end of next year, we were done with all the sub-counties in this country with a health center 3, and at least with some basic accommodation for midwives and nurses. Just to remind you that actually in this country, our health center series deliver the biggest number of mothers. So as we address the problem of maternal health, we emphasize the area of health center series.
Okay.
So we are having all health center series having adequate accommodation, plus the maternity and labor suits. We are having our health center force having accommodation, especially because we want all health center force to do cesarean sections. Currently, out of about 200 health center force, 186 are doing operations. So those facilities need accommodation, especially for the anesthetists and the doctor to stay on the facility, as some of those operations take place at night, so you cannot start calling a doctor from town where he's staying about 5 kilometers away to come for an emergency at night. Even at the general hospitals, we are rehabilitating quite a number of hospitals. I wish they could show some of the staff accommodation that we are building in the camp. So it's not only money, but also good housing. It's very motivating.
Yes.
And we are even prioritizing it in our next development plan, the next 5-year development plan. The emphasis is being put on staff accommodation.
Okay. Well, talking about money in the other aspect of affordability, there are a number of super specialized hospitals that have come through thanks to Ministry of Health and the people of Uganda who have probably paid the taxes to ensure that this comes to pass. For example, the Neonatal Women's Hospital at Mulago, we have one super specialized hospital being built in Lubowa, but for Ugandans, it is the issue of cost. Can they afford these super specialized hospitals? And yet they would need them at some point.
They will need them at some point. But as we are saying, those super specialized hospitals, which most often require cost or paying for some of the facilities, are really super specialized for conditions that may not be handled at the National Referral Hospital, at the regional referral hospitals. And we have adequate facilities at the regional referral hospitals, at the National Referral Hospital, to handle most of these conditions. So it's the specialized conditions that will go to those super specialized facilities, and therefore there will be the screened cases. And in some situations where somebody cannot afford, and this is a referred case, then there will be forms of exemptions for those cases that cannot afford the super specialized. But normally most of our regional referral hospitals, they have the specialists, they have the equipment. We have equipped most of those facilities, regional referral hospitals, to handle most of the referred cases from lower levels, from, let's say, general hospitals, and from health centers. They should be handled at regional referral hospitals.
All right, our time is really getting fast spent. I feel like the discussion has just started, but I'll give a few minutes to each one of us as we get to conclude. I'll start off with you, Mr. Okware, talking about your achievements as national medical stores, but also if there is a change in law, because currently you are supplying government hospitals or government health facilities, what are some of the gaps you think should be cleared for you to be able to supply the private health facilities as well?
Thank you for that, Mildred.
And I'll get your closing remarks as well.
Okay, thank you very much. As I had shared, our mandate is primarily to the public health facilities. But there is also an opportunity to work with the private sector as well. But our focus has been, first of all, to see if we can serve the public health facilities to a level where we believe that we have covered them well enough, and then see if we can engage with the private sector. But we don't want to get in the private sector to compete with other service providers who are providing the same kind of service. We believe that we can look at other gaps within the health system and see how we can cover those. Right now, we are developing a lot of capacity in terms of warehousing space in Kachansi. We believe there is a lot we can do there and provide it for other partners and even for other government agencies, those who require storage and distribution of commodities. And this would allow us generate revenue that could even make the operations at national medical stores even more sustainable in the years to come. So those are areas where we believe there's an opportunity for growth for us also. Okay. We also think that we can do a lot in the area of information. We are installing our ERP, and we believe very soon we shall have a lot of data coming through from the health facilities.
For the benefit of the viewers, ERP meaning?
Oh, that is the Enterprise Resource Planner.
Okay.
It's the software system that we have been talking about. Okay. We want to see if we can plug any potential gaps, especially when it comes to the facilities planning and how we can have better information on what their needs are. There are so many actors within the health space outside the Ministry of Health here who need this information to see where they can support government in many disease areas. And if we can get this information, we believe we can do a lot there to support the government to grow.
All right.
Yeah.
Thank you so much. And Mr. Nahamia, let's look at some of the achievements of National Drug Authority. And you earlier on talked about the aspect of pharmacovigilance and reporting of side effects. How do I, as a Ugandan who has gotten adverse side effects or particular side effects from a drug, be able to reach National Drug Authority? I last heard that you have a med safety app that was developed to deal with that. If you could expound much more on that.
Yeah, thank you very much, Mildred. But before I go to that, there's something I mentioned in passing, maybe you didn't realize its importance when I mentioned that the National Drug Authority has a lab which is WHO pre-qualified and at level 4.
Okay.
It means that the test results from there are recognized internationally. And we also have one of the best labs for medical devices. As I talk now, even some countries, if it was not for COVID, they were approaching us to come and train. Some of those countries, when they came around, they got mesmerized. They say, what, we got Europe. In other words, we are sitting on gold. Maybe people didn't know. So we really have achieved a lot in that. In addition to that, we are a center of excellence in GMP, recognized by NEPAN. This GMP audits I've been talking about, we have really developed capacity and skills in that area, and I would really say we are recognized. Then on the issue of pharmacovigilance, as I've mentioned, that made safe we wanted to digitalize so that people were not willing to do a lot of filling of these forms. We thought that made safe app will help us really facilitate the reporting on some of these adverse events, and especially for COVID. We have received some few reports, we're analyzing them. And I would also like to say that in this COVID pandemic made us achieve some of the issues in our mandate. We are supposed to ensure that give technical support to the local manufacturers. And I can foresee that in the next 5 years, we should be able to reduce the dependence on imports. We are now importing almost 85%. You can imagine when there was COVID, there were flights, ships were not there, what would happen? But as I talk now, we are rapidly able to answer the mandates of the ministry. For example, we gave technical advice people to manufacture PPEs, masks, sanitizers using the local raw materials. Our team was able to move in so fast. We even approved around 50 manufacturers of these surgical, and of course, even those who wanted to export to maybe Sudan, neighboring countries, they said, you have an approval from India. You can see how recognized the National Drug Authority in the region is. Even when you go to Sudan and the neighboring countries, exports from here are highly appreciated. So really, and as I talk now, we are putting up a state-of-art laboratory. I think it's going to be the best in sub-Saharan Africa. And as I talk now, also some countries are approaching us to analyze for them some of the devices like gloves, condoms. We have expertise in that. And we are going to train other people in the region.
Congratulations.
Therefore, we are sitting on gold.
I believe so. I believe so. And this gold needs to be explored much more.
You need to expose it further.
Yes, exactly. Yes. Our time is really running out. Professor Pontiano, your concluding remarks, but also just briefly talking about your contribution to policy as UVRI.
In my concluding remarks is that we have an ambitious program as UVRI in terms of research. We do our strategic plan to identify areas of research that are important, but I can tell you COVID will remain key, and other emerging, re-emerging infections and HIV. Innovation, we're also thinking about innovation. We started talking about COVID vaccines recently, but we have been moving in that direction. We're trying to make vaccines for Rift Valley and others. We shall really be moving in those directions. Training, we have not talked about training. We do a lot of training. Currently, in the last 4 years, for instance, we have trained more than 60 PhDs. Yeah, a lot of training, and we need these middle-level scientists who will be able to attract funding and do research. And then infrastructure, we have talked about houses. We are really making sure we are lucky at UVRI. For us, we kept our houses. We didn't sell them. Against the advice, we didn't sell them, and we're renovating for our staff, but we also want to put up the big science building and become even more visible. Our work has to inform policy and practice, and work very closely with our colleagues in the Ministry of Health. If there's anything, first of all, they're involved in our planning of our research, so that our research has relevance to policy and practice. Yeah, and as we have talked about treatment, we have talked about prevention, we have talked about addressing emerging infections. So we need to continue working to ensure that our work is relevant in addressing our health needs in the country.
All right, thank you very much, Professor. Dr. Mwebesa, as we get to conclude on this, would be the issue of finance and administration, which I think Dr. Atwine will be responding to. But as you give your concluding remarks, would you kindly highlight on what many have called a fake diagnosis from the different medical facilities, especially the private medical facilities, or wrong diagnosis?
With respect to COVID or generally?
No, generally, and how that does affect the healthcare system.
Okay, thank you very much. First of all, in my concluding remarks, I really want to appreciate all our health workers for the very good work they have done, especially in controlling epidemics and pandemics. And these 335 cases we are seeing is not by accident. We didn't just get them because the COVID which was here was light or not as aggressive. It was a deliberate effort by strong systems which have been put in this country, and that has managed to manage this pandemic. I also want to thank them for continuity of care. Even in the midst of COVID, we continued with the delivery of other services like the normal hospital services, health center services, and all the rest. I want to thank government for the support in financing most of these interventions, including the disease prevention and health promotion, and the infrastructure that we've been talking about, right from health center 3 to specialist facilities that we talked about. But in all this, we also worked very closely with our development partners. They have been very strong, and they have supported us immensely, and we really appreciate it. Regarding fake diagnosis from especially the private sector, we'll continue to monitor it. We have a very strong laboratory system in this country and monitoring system. We have very well accredited laboratories in this country, and the supervision system from the center to the lower level facilities. We shall trigger more action to go and supervise more of these laboratories, because once you get fake results, that means you are putting people on unnecessary drugs. One of the common things we see is when laboratories are diagnosing everybody typhoid and giving them a lot of capsules for nothing, unnecessary capsules. From there, they go to other conditions, but that is mainly because of unreliable laboratories, which we shall continue to supervise and strengthen to make sure they follow the standards and they meet the required guidelines.
Thank you very much, Doctor. And finally to you, Dr. Atwine, in your concluding remarks, if you could just talk about two key issues that have been covered: the rampant outages, power outages at healthcare facilities. We've covered, stories of halted operations, probably because there are power outages. And our report from our Northern Bureau Chief is that Acholi, Lango, and West Nile actually do not have a CT scan.
Yes, it is true. We still have a challenge of power that keeps on fluctuating, or it's not there. We have addressed these issues to the relevant ministries. I hope they are addressing them. However, we encourage also the individual facilities to plan for the generators, so that when such a outage takes place, they are able to have alternative source of power so that we don't interrupt our operations. It is true that some of our facilities do not have the CT scan, the regional referral hospital. By the way, it's not every facility that you'll expect like a CT scan. There are certain level of services that are different levels. The CT scans are supposed to be in regional referral hospitals, and right now, Arua, Gulu, and Lira, they are under renovation. Actually, by now it should have completed, and we expect really after that to have those CT scans. It is also our plan to have that equipment in all regional referral hospitals. We go according to what we have, the resources that we have at hand, You see this time around when we had COVID, it was a priority to make sure that we put the ICUs in the facilities, although some facilities still, they don't have adequate infrastructure. But that is our plan. We are going to continue. As I conclude, I just want to say that Ministry of Health is a big sector. Yeah. When you call us here, it's like we have not talked about anything.
Yeah, sure.
We have literally just conversed with you and finished. We have not actually given you the real information that the public really needs, because we have had so much misinformation, so many distortions, so many things that we need really to come and help the public to understand. Yeah. I want to tell you that Uganda, as far as health is concerned, we are doing very well. We have come from some level, and I want to tell you that we are going higher. I want to tell you that these facilities we are talking about here, I'm so proud of, for example, UVRI. I don't know how many of you know that they have discovered so many viruses, and I was like, my goodness, how many viruses I've lost even track. Recently, they got what they call Ntwetwe virus. Have you heard that? You don't know. They've discovered Ntwetwe Nchankwanzi. There's a special virus. There are so many researches, so many things that are taking place in the country, but people don't know. For example, if Paul tells you that the warehouse we are going to have, it is one of its kind on the globe, on the continent, people will not believe. And even if you tell them, they say, oh, you see, what? And they don't believe in our own people. Dr. Podoi in Soroti, who was able to operate, this is just a surgeon, but because he believed in himself and he was able to do this, so many people are doing that because it's just, we are talking about Soroti, but there are so many things that are happening in our facilities that do not catch the eye of the media.
Sure.
But I want to tell you that it is high time that we believed in ourselves. The National Drug Authority, the work they are doing and the facilities they are setting up, the state of the art, that we shall be earning money from all these neighboring countries, it is something that we should be proud of. Not demonize, the health sector is shining. It is rising and shining. And I can assure you, if only we get support and not tie our feet and hands down by all this negativity around us. We have so much energy. We want to serve our country.
Okay.
And so we just call upon you to support us, so that we walk on this journey and we provide services and you trust in us. We have competent health workers. If we have been able to control COVID to this level and we in the region, you look at what we have done. And it's not only just for COVID, even other diseases. We have provided support to other countries. Ebola, remember, in West Africa, we had to send our people, our experts. In Congo, we are able to control the Ebola from coming here. All that is the effort of our health workers. We need to be proud of what we have. Thank you so much.
You're welcome. And just like you say, true, the health sector is a huge one, and I also feel like the show had started. But unfortunately, our 2 hours are out. We will definitely have to get another edition of Spotlight, speaking still about the health sector of Uganda. But we unfortunately have to end it at this. Thank you very much, Dr. Mwebesa, for sparing time to be with us. Professor Pontiano, it's been a pleasure. Mr. Nahamia, thank you so much. Mr. Kware, it's been a pleasure. And to the PS, Dr. Diana Atwine. For those who have been watching us on NBS and UBC also, thank you so much. And allow me to say a good morning to you. Happy Tuesday. We're getting back to work. It's already morning. And thank you so much for being with us.
Thank you.
Your health matters, and every single day a thought crosses one's mind on how it can be better. We want more. Matter of fact, for many of us, we deserve more. But do we know who to ask for what in as far as Uganda's health system goes? From accessibility to healthcare across Uganda to service quality, how much has been done and how much more is in the pipeline? Spotlight this Easter Monday addresses Uganda's healthcare status while shining a light on where we are and the future. On the panel, Dr. Diana Atwini, the Permanent Secretary of the Ministry of Health, Dr. Henry Mwebesa, the Director General Health Services at the Ministry of Health, David Nahamya, the Secretary to the Authority of the National Drug Authority, Moses Kamabale, the General Manager of National Medical Stores, and Professor Pontiano Karebu, the Director of the Uganda Virus Research Institute, as moderated by Mildred Tuhaise. Spotlight UG, Mondays at 10 p.m, live on UBC Television.
Winston Churchill named it the Pearl of Africa. Uganda is probably one of the most gifted countries